up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Keep moving. Keep moving. Keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is yours now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here we
A very good afternoon to all the participants here and the panelists over here. Now we are going to start our session, exercise and injuries. The first session, for the first topic for this afternoon session is exercise and low back pain. And
Good
we have
afternoon, everyone. Welcome to World Conference on Exercise Medicine. Greetings to you all from India. The topic for today's presentation is exercise and low back pain. My name is Srikanth and I am CEO of Elite Physiotherapy. Today I am going to discuss about effects of exercises on low back pain. We are going to see the introduction to low back pain, types and etiology of low back pain, and effects of different kinds of exercise on low back pain. As we all know, low back pain is an important public health issue in all industrialized nations. It is a common condition and the leading cause of global disability according to Global Burden of Disease studies. Low back pain is considered as the second most common cause of missed day works. 60 to 90% of adults experience low back pain at some point of their time. Low back pain incidence increases with age. The lifetime prevalence of low back pain is estimated to be as high as 84%, and 1 year prevalence is estimated to be up to 65%. Low back pain adversely affects individuals, their families, communities, and governments worldwide. Furthermore, the economic burden of low back pain is growing due to absenteeism to work, loss of productivity, and costs of treatment expenses. The recurrent nature of low back pain is one of the major reasons why the condition carries such a large social and economic burden. Low back pain is categorized into non-specific and specific low back pain based upon the etiology of back pain. Non-specific low back pain refers to back pain which don't have any specific pathological reason. Any back pain which is because of some specific pathological issues is considered as specific low back pain. Among the two, non-specific low back pain is the most common type of low back pain which occurs and accounts for about 85% of all back pain cases. Non-specific back pain is defined as low back pain which is not attributable to a recognizable or known specific pathology. It is also called as mechanical low back pain. Based on the duration of back pain, non-specific low back pain is categorized into three subtypes: acute, subacute, and chronic low back pain. Any pain which subsides within 7 days is considered as acute back pain, and any pain which lasts from 7 days to 7 weeks is considered as subacute back pain, and any pain which lasts more than 7 weeks is considered as chronic low back pain. Here in this topic, I am more specifically talking about non-specific low back pain. There are many reasons for non-specific low back pain. It can be non-specific low back pain can be because of traumatic injuries to the muscles and ligaments around the back, which are lumbar sprain or strain, or it can be because of postural strain. On the other hand, specific low back pain is defined as pain due to some pathology. The pathologies concerning with the bones or vertebrae or disc related issues or spinal deformities. If you see the bone related issues, degenerative conditions of the spine such as spondylosis or spondylolisthesis where one vertebrae run over the other vertebrae, and fractures of spine or vertebrae can lead to low back pain. And then disc related issues such as disc bulge, disc prolapse or herniation of disc are also causes low back pain. Spinal deformities such as scoliosis where the spine is bent to one side, or lumbar lordosis or kyphosis all leads to low back pain. Spinal pathologies such as ankylosing spondylosis or metastasis in spine like cancer growth in the spine also can lead to low back pain. And in some cases, any organ issues which are far from the back also can lead to pain in the back pain, which is called as referred pain. Organs related like kidneys or kidney stones, ovarian cysts, and uterine problems can lead to low back pain. There are many reasons for non-specific low back pain. If we see, it can be a poor body mechanics, stressful living and working habits, decline in general physical mobility, or physical fitness due to aging and immobility can lead to loss of flexibility and loss of strength. In turn, can lead to low back pain. If you see now, because of COVID-19 pandemic, a lot of people are working from home and their mobility also reduced. All these situations can lead to low back pain. If you see poor body mechanics, lifting heavy objects with narrow base of support can lead to back pain. Or sometimes while lifting heavy stuff, sudden twisting or holding a heavy load from far also can lead to increase in strain on the back, leading to low back pain. Sometimes working in awkward positions or uncomfortable positions, especially when we are working from home, people tend to sit everywhere. They sit in a chair, they sit in a sofa, which can lead to strain on the back. Sitting or standing too long in one position also can lead to low back pain. Stressful living and work habits. Improper lifting of weights at home can lead to low back pain. Working from home, especially during this season, has put many into stressful situations. People, because gyms are not open, people tend to work out from home, and many people end up with low back pain while doing exercise at home. It can be because of the warm-up maybe not enough, or wrong technique of lifting, or overdoing exercises also can lead to low back pain. Most symptoms of low back pain resolves within 6 weeks in 70 to 80% of affected patients, regardless of intervention or no intervention at all. A small portion of about 5% people suffer persistent or recurrent pain, leading to prolonged disability. There is always a strong association between physical activity and low back pain. Physical activity is defined as any bodily movements produced by skeletal muscles that results in energy expenditure. It has been hypothesized that physical inactivity may lead to reduced muscle strength and flexibility, and consequently may result in spine being susceptible to injuries. Its own empirical evidence is lacking. If you see the back injury cycle, any person who is having back pain tend to limit the movement. If he is limiting the movement and stop moving completely, he will develop stiffness in the back. This stiffness leads to muscle weakness, and muscle weakness again causes a back problem. That's why people with low back pain have to start moving around as soon as possible. If no, means the back pain going to be last for longer time. There is a systematic review done to find out the association between physical activity and low back pain. The reports of the study shows there is an inverse association between physical activity and low back pain. People engaged in medium level physical activity have a 10% lower risk of low back pain compared to those engaged in low level physical activity. It is recommended for patients with non-specific chronic low back pain to remain physically active as long as periods of inactivity will adversely affect recovery. Exercise therapy seems to be an effective treatment to relieve the pain and to improve the functional status of the patients with chronic low back pain in most clinical practice guidelines. Within the umbrella term of exercise therapy, several types of exercise therapy exist, such as core stabilization exercises, also called as motor control exercises, strengthening or resistance exercises, stretching exercises, and aerobic exercises of low to moderate intensity. There are many forms of strengthening exercises. If you see abdominal crunches to improve the strength of the core muscles in the stomach, elbow to knee to strengthen the stomach muscles, spinal extension exercises to strengthen the lower back muscles or the core muscles, and then wall slides to improve the strength of the lower limb muscles. All these strengthening exercises will improve the strength of the core muscles, in turn reducing the lower back pain. Another form of exercise is a stretching exercises for the back, which improves the flexibility of the back muscles, so decreasing the recurrence of the back pain. There are many forms of stretches, like knee drop, where the client will be lying on the back and bending the knees and then moving the knees from one side to another side, holding the position of extreme end for 30 seconds of each. And another form of stretching is knee to chest, where the client is advised to bend the knee and move the knees towards the chest and maintain the position for 30 seconds. And then hamstring stretch. Hamstring muscle stretching also decreases the strain on the back. Hamstring stretching is also advisable for people who are having low back pain. Along with strengthening and stretching, one more component is pelvic mobility exercises. This pelvic mobility exercise improves the movement of the spine. There are various ways of pelvic mobility, mobilizing pelvis. Pelvic tilting exercise where the client will be lying on the back and lifting the hip above and then coming back to the bed. And another form of pelvic mobility exercise is cat and camel exercise where the client will be going on the four extremities, legs and hands, and slowly advised to move the lumbar area up and then down and holding each position for 15 seconds. There is a systematic review done on the effects of exercise therapy in patients with acute low back pain to find out whether exercise therapy is effective in reducing low back pain on a long term or not. The results of the systematic review shows that there is moderate certainty evidence suggesting no superior effects of exercise therapy when compared to conventional treatment modalities. And very low certainty evidence suggests that stabilization exercises together with medical management may be superior versus only medical management for recurrence at long-term follow-up. The effects of 1 to 8 weeks of exercise may not remain 1 year later unless exercise is maintained. So any exercise session for that episode of low back pain is not enough to prevent the recurrence in future attacks. A meta-analysis done on the core stability exercises versus general exercises for chronic low back pain. This meta-analysis, which includes 414 patients, identified 5 randomized control trials that states that compared core stability exercise and general exercise for chronic low back pain. The results of this meta-analysis indicates that core stability exercise is better than general exercises for pain relief and improving back-specific functional status in the short term. However, no significant difference in pain relief were observed in the intermediate and long-term follow-up periods. There is a review article on the effectiveness of strengthening exercise for elderly with low back pain to improve the symptoms and functions. The results of the studies on the intervention of low back pain in elderly people have recommended that strengthening exercises helps to elevate the pain and improve body function. And there is another study done on the periodized resistance training for persistent non-specific low back pain. In the study, authors investigated the feasibility of a 16-week periodized resistance training program, starting with very light loads in the first 4 weeks and then utilizing heavy loads in a weekly undulating periodized model for 12 weeks. Others observed clinically meaningful reductions in low back pain and improvements in pain-related disability, pain self-efficiency, and muscular strength. A systematic review of the effects of exercise and physical activity on non-specific low back pain. The results of the study shows that moderate intensity aerobic exercise, 40 to 60% of heart rate reserve, should be promoted for non-specific chronic low back pain rehabilitation. A core stabilization program combined with muscular strength is superior to core muscular strength exercise alone. Improving the flexibility of the lumbar spine and hamstrings can significantly reduce chronic low back pain by 18.5% to 58%. Exercise intervention programs involving either muscular strength, flexibility, or aerobic fitness is beneficial for non-specific chronic low back pain patients, but not acute low back pain. An article written in the ACSM's Health and Fitness Journal states that research indicates that excessive activity reactions are in fact the opposite of what a painful back needs most. When outcomes from patients treated with bed rest are compared with those of patients who continued with work or activity despite pain, faster recoveries occurred for the activity group. That's why a patient with low back pain are advised to move around as soon as possible and as soon as the pain permits. Take home message from this presentation is, it is recommended for patients with non-specific chronic low back pain to remain physically active as long periods of inactivity will adversely affect recovery. Most symptoms resolve within 6 weeks in 70 to 80% of affected patients. Proper body mechanics and posture can prevent the recurrence of low back pain. Exercise therapy seems to be an effective treatment to relieve the pain and improve the functional status of the patients with chronic low back pain. These are the references. And thank you very much. I would like to thank Dr. Jessie Lai and Dr. Lee and the whole organizing committee for giving me this opportunity. Thank you. Thank you very much.
Dr. Srikanth, how are you?
I'm good, Doc. Thank you.
Thank you very much. I'm so sorry I didn't get the opportunity to introduce you before you present your paper. All right. There was a small glitch that Dr. Bakesh is supposed to be there. I think there are some technical issues in Hungary. All right. For ladies and gentlemen and delegates over here, I would like to introduce you all who Dr. Srikanth is. Can I have Dr. Srikanth's CV, please? He has a master's in physiotherapy. If I'm not wrong, his thesis is on exercise, sports medicine, in particular, where he looked into the cardiovascular system. We were colleagues about 15 years ago, all right, while we were running a physiotherapy school. And he is also an editor-in-chief of an international scientific journal in physiotherapy. And he managed International Journal of Physiotherapy and Research and Training Healthcare. He has completed his certification program in dry needling from India, instrument-assisted soft tissue manipulation from Singapore. A man who has a lot of high qualities in the field of physiotherapy. So my apology again, Dr. Srikanth, because there was a glitch here. So anyway, thank you for accepting our humble invitation to present a paper here. And I would like to request you to chair the rest of the symposium here in this group, as I could not reach Dr. Bakesh. Is that okay with you?
It's my pleasure, Doc. Thank you very much.
All right, thank you so much. All right, please carry on. Thank you again.
Is there any questions from the floor?
Dr. Srikanth, will you carry on?
Yes, Doctor.
Okay, I think there will be questions and answer for Dr. Srikanth's paper, isn't it? All right, I think you have two questions here. What is recommended weight for slip disc client to do weight training after recovery?
When it comes to slip disc, actually we have to see certain components, whether the slip disc, how much percentage of slip disc has happened. And based on that, let's say like slip disc grade is only grade 1 or grade 2, we can still go with exercises. We can prescribe exercises, but we have to see the direction of the slip, whether the slip disc is in the posterior, the disc is going posteriorly or posterolateral aspect. So certain exercises we prescribe is like we go with flexion exercises, and let's say like you want to go for extension exercises, you have to see carefully like which direction the slip is going. And then in terms of like weight, you want to prescribe weight, you have to make sure you see the physical dimensions of the patient, and then his physical capacity apart from disc bulge. So based on that, we'll do the weight. Usually we start without weight first, then gradually we increase.
Yes, that's good. It's a very conservative answer to this a very what we call a tender injury, especially the disc is concerned if there's a herniation of the disc. The second question is that can a spondylolisthesis patient continue jungle trekking?
Spondylolisthesis also we have to be very careful, because if you go for jungle tracking, let's say like you're hyperextending your back, there are more chances for the disc, for the vertebrae to move forward. So it's always, let's say like you want to go for jungle tracking and the spondylolisthesis is only grade 1 or grade 2, still it's advisable to wear lumbosacral support. Then you can go for jungle tracking, and then you should always be careful with the movements as well.
Thank you for your answer. You have one more question. What exercise is good for a person with spondylolisthesis? Spondylolisthesis. How long does it? This is one word that really. And how long does it recover?
Spondylolisthesis, again, I am telling the same, like we cannot go for spinal extension exercises for a patient with spondylolisthesis. So always we have to prescribe them flexion exercises, Williams exercises or the flexion exercises, and improve the core muscles of the stomach. We cannot prescribe them extension exercises as it may increase the spondylolisthesis grade.
Bring her here now, eh?
So I suggest flexion exercises.
All right, thank you very much. I think that's it. Once again, thank you for your presentation and your paper, Dr. Srikan. So kindly chair the symposium for the conference. All right? All right, thank you.
So we move on to our next presentation. So say our next presentation is by Dr. Edgar Michael. He's a Cardinal, he is attached with Cardinal Santos Medical Center. He's a chairman of the Department of Orthopedics of the Cardinal Santos Medical Center. He's a medical director of the Peak Form Sports Recovery Center and is a head of the Ortho Rehab Rheuma Division of the Mega Clinic. He's a founder of UPPGH Department of Orthopedics Sports Clinic and was its head from 2000 to 2010. He's a president of the Philippine Orthopedic Society for Sports Medicine from 2011 to 2014 and was also the president of the Asian Society for Sports Medicine. So without further ado, I would like to welcome Dr. Edgar to take over the session.
Hello, everyone. Thanks for having me. It's an honor to be here to present some of the work that we've been doing the past few years. I'd like to present a compilation of some of the cases that we've been doing on soft tissue and bony injuries without the use of metal implants. So the title of my talk is Say Goodbye to Implants. So my whole fascination with the implantless technique started more than 15 years ago. We had a teenage female who had a near open clavicular fracture. She was on the thin side, so when we discovered that the configuration was a long oblique fracture, we checked with their parents if it was okay for us to use the implantless technique. No? That way we can avoid having the prominence of the plate and the screws. No? So after more than 10 years, fracture healed very well. She actually put a tattoo over her incision, which looked pretty nice. And her function has been very well. She's a singer with a lot of hit records since then. In 2008, I was part of a sports traveling fellowship program in Europe. That's where we met a lot of the prominent people in sports medicine. One of whom is our chair, Professor Istvan Berkes. He showed me his version of the implantless technique, which inspired me to come up with my own version of the same technique. No? During the same trip, we met other prominent people in sports medicine, Professor Hans Passler and Professor Rainer Siebold. No? They've been also very helpful in introducing things to me to make me think more of the different ways that we can improve on certain procedures. So the first implantless surgery we'll discuss will be the implantless ACL reconstruction. So Professor Passler's technique, which is used on a lot of the elite athletes in Hungary, uses the bone patellar tendon bone autograft. Professor Passler's technique includes the bone patellar tendon with a double horizontal incision. Our version will be also using the bone patellar tendon autograft, but with a single vertical incision, which we later will add another small incision for the tibial portal. So this is how the graft looks like after it's been prepared. The bone plug will be around 2 centimeters, and it will be tapered at the end like a bullet. And the whole construct, if we can make it fit, will be around 6 centimeters. So this is how the femoral side looks. The femoral bone plug, as we bring it in, we try to make the bone plug slightly bigger than the tunnel so that it does not readily enter the tunnel. No? And then with the use of a bone tamp, we hammer in the last ½ centimeter of the protruding bone plug to have a nice interference fit. On the tibial side, we use what we call the bone bridge technique, which you'll see in a lot of the other procedures that we'll be discussing later on. So as you can see here, it's composed of drill holes on the tibial cortex. Then we pull the sutures through from the tunnel, exiting the cortex, giving you the classic bone bridge look. So very slight differences from our standard ACL protocol. Because we worry about the pull out of the bone plug, no, we are a little more careful during the first 2 weeks. No, instead of the full weight bearing that we normally allow for other ACL patients, we put them on 50% weight bearing with crutches first. They're able to walk, but with the knee in extension. No, then we do passive range of motion. After 2 weeks, we treat them as if it's the first day of the regular ACL, no? ACL reconstruction. So the return to sport is actually more or less the same. No? We get them back roughly at 8 months. The next technique is an Achilles tendon rupture. Most of the ruptures we see are mid-substance, although some will be musculotendinous and some will be avulsion injuries. A lot still do mid-substance repairs with the aid of maybe suture anchors to help with the healing, no? But we'll present our version of the Achilles tendon repair, which later on we will show together with the other versions of an Achilles tendon injury. So very important is for us to remember, because like the bone bridge, you probably see this suture technique often enough, no? During the course of the lecture. So we use a Kessler-Tajima technique. So Professor Kessler and Professor Tajima both have techniques that they use for flexor tendon injuries of the hand. We incorporate both into our procedure. So what we do, our suture starts from one end of the stump, exiting the side. Then you go from side to the other side. And then you go from the side, entering the other end. No? So it's an end-to-end, side to side, end to side, and then a side-to-end suture. No? So we'll do this with around 2 to 3 strands on both sides, no? So the proximal and the distal stump. So when we have the look of the tendon right before the sutures are put in place, no? That's how it looks on the left, and on the right is when the sutures are already set, which affords a good reduction of your tendon tear. No? So we're confident enough with the repair so that after the procedure, even before the patient wakes up, we're actually able to do a Thompson test, which is a test to see the integrity of the Achilles tendon. And as you can see here, that's a negative test, meaning there is plantar flexion of the foot when you squeeze the calf. No? So our suture technique, our whole technique, if done early enough and properly, you don't have a very big incision. In this case, we have around 3 centimeters or 1.5 inches. So the first day post-op, we don't do the usual long immobilization. In fact, we allow them to do active range of motion right away. As you can see, the patient is able to do dorsiflexion back to neutral already. You know? We even allow immediate weight bearing as long as they walk in a cast boot. So here are 2 athletes that we can show that 1 day post-surgery, as long as they're confident with the movement and that the pain is acceptable, no, are able to do certain activities that normally would be very fearful, no, for a lot of our patients. So we do progressive strengthening within safe movements, no, such that by 4 weeks, we even allow them to do active resistive exercises with resistance bands, no. So this is the gold band, which is actually the highest level of resistance. So the patient was quite confident with it. And at 6 weeks, we actually allowed them to take the cast boot off already and start weight bearing with the normal gait. No, so this is our patient's first day without the cast boot. So he did a pretty good job. So we start the strengthening to the point wherein we allow them to do active resistive with dumbbells, doing heel lifts. No, so this is the patient as he was approaching 12 weeks. No, so this is him at 12 weeks where we allow actually a running program. They go as high as 16 kilometers per hour. So he was able to do this at around 3 months. No? So at 4 months, we progress them to sport-specific drills. Usually a lot of them get back to competitive sports by their 5th month. No? So these are just some of the things that they've been doing to help hasten their recovery. So the Achilles tendon injury, as we said, does not always just come out as a mid-substance tear. No? Sometimes, unfortunately, patients end up with an avulsion, which normally is a more difficult thing to treat. And a lot of times they need to have suture anchors or other implants to help in the repair. No? So this patient actually, when you compare the left and right heels, no, patient has a Haglund's deformity on the injured side, no, which is that painful, that pointed part there, no. So we normally have that deformity rubbing on the Achilles tendon, resulting in a mid-substance tear, no. But this patient had something different when we entered, no. You can see here her Haglund's deformity. So we obviously have to treat that or get rid of that before we do the repair, no? So we did an excision. So you can see on the right, after we did our suture technique on the tendon, no? You can also see the osteotomized area of the calcaneus, no? So we drilled our holes, and you can see as we prepare for the bone bridge technique, no? The drill holes come in this fashion, no? The 2 are posterior and 2 come anteriorly. So as we pull the sutures through, you have a reduction of your Achilles tendon into the calcaneus, no, simulating a new attachment. Then we suture everything down. We also are confident enough that we actually will try a Thompson maneuver, no, during the surgery before we close. So here you can see a negative Thompson test. You have plantar flexion of the foot as we squeeze the calf. No? So as you can see, the incision of this patient is a little more distal since we have to expose the calcaneus as we try to do our repair. But patient is also able to do active dorsiflexion, hopefully until 90, and we allow weight bearing almost immediately. No? So this is the patient 1 day post-op. Next case we'll be discussing is a comminuted patellar fracture. So this is a 70-year-old female with a history of a fall. So she sustained a 4-part patellar fracture. So normally these would be treated with metal implants, usually a coarse wire and then K-wires. No, so a lot of things need to be done, including probably delaying the range of motion, because as you can see, it's a pretty comminuted injury. No? So the technique we do here is once we see that the parts may be put back together, no, it's not, the comminution does not have too many pieces and you can put them together. We treat it first like a patellar tendon rupture, no? So we actually detach the patellar tendon from the inferior fragments. As you can see here, they kind of fit nicely as you try to put them back together, no? So we separate the fragments inferiorly. So in this case, from a 4-part, you convert it to a 3-part, and then from a 3-part to a 2-part fracture. So this is the best fit that we could put the fragments in. And we do the Kessler-Tajima technique on the patellar tendon. And you do it like a barbecue technique, no? Like a shish kebab technique. So you put the 2 ends together of the bone, and then you drill through the inferior pole, exiting into the anterior pole, no? The superior pole. So you get to the top, you get 2 two drill holes converging as they go superiorly. Then when you come to the top, you do your usual tightening, and then you try to repair the remaining patellar tendon stump to itself, and then try to bury the knot so that they don't have too much of a risk of bursitis later on. So this is how the repair looks like afterwards. No? So patients seem to do much nicer with this technique, no, other than them not feeling the metal around the skin area when they palpate it. 1 day post-op, we're able to drop the knee passively to 90 degrees. And with the aid of a hinge brace, we're able to get them to do full weight bearing with normal gait, no, by 4 days. We continue the range of motion such that at 2 weeks, they're already able to achieve more than 120 degrees of flexion. And with the swelling down and with the wound already healed, no, we can actually start them on first with unresisted biking, no, at 2 weeks. Then we progress to resisted biking. We actually allow already eccentric contraction by 6 weeks. So this is the patient's first day to try the eccentric contraction. So from a standing to sitting position and with alternating steps going down. No? So we think the patient did pretty well considering this was her first day to try eccentric contractions. No? Then we progress to strengthening. By 10 weeks, they're actually already in the gym lifting weights. So doing a leg press, this is starting at maybe 1/3 of her body weight. So not bad, no? She's only 2.5 months from the surgery. Her range is full and the strength is recovering. So we tell them that by 12 weeks or the end of 3 months, they're actually allowed to do all the activities that they've been doing before. No? So if it included sports, then we'll clear them for that. So our 12 weeks post-op x-rays are nice enough. No? If you can see the healing is almost anatomic and there's no signs of any malunion or a non-union. So we monitor the patient for pain and all the other things, and patient has been doing well until now. So next would be patellar tendon rupture. So we see a lot of these also in the athletes, no? So as you can see from the x-ray, there's patella alta, and from your MRI, there's a clear view, no, of the mid-substance patellar tendon rupture. So we use the same technique that we showed with our patellar fracture, no? So in this case, since the patella is intact, our drill holes are eyeballed, no, from the inferior pole going to the superior pole, as I said, in a converging manner. No? So we put our drill holes through, and then when the sutures are near ready to be tied, no, so we do a trial reduction by doing a flexion extension of the knee. And once we achieve that, so we tie it down, and then the tendon stumps are then repaired. No, so this is how our construct will look after. We also bury the knot, no, to prevent bursitis later on. So we do the same things as the patella, no, but since this one was in a younger individual at 12 weeks, they're started on sport-specific drills, and actually they're allowed to return to sports, no, by the end of their 4th month. So it's pretty quick recovery, no, considering that it's an implantless technique. So we go to the upper extremity now. We see some of these more often as the athletes now tend to push themselves when they do their training regimen. No? So we see a lot of the distal biceps tendon avulsions. No? So some MRI findings showing the injury, and there's definite retraction of the tendon stump, no? As you can see through the MRI. So this is the reverse Popeye sign with the patient trying to do a resisted elbow flexion. No? The biceps belly, no, starts moving proximally. So we modify our incision to be a little more cosmetic. No? We try to make it a little smaller. No? So we do a curvilinear incision right above the elbow crease. So using the same suture technique on the tendon stump, we also look for the proximal part of the radius, where to see the attachment of our our biceps, which is in the tuberosity. No? So this is how we introduce the sutures. No? We mark our area where the tendon came from. No? We have the two techniques, the two drill holes, making it look like the for our bone bridge technique. No? So each will come in through the radial tuberosity, exit posteriorly, and then we do the knot at the back. No? So this is how the tendon looks after being sutured down. And as you can see, with the patient still sleeping, that the reverse Popeye sign is no longer there. No? So we start range of motion at around 2 weeks, being very careful. So since we know that the biceps is an elbow flexor while the forearm is in supination, no? So it's also a strong supinator. We do careful range so as not to stress the tendon, no? So we can do flexion extension and we can do pronation supination, but not at the same time, no? So we try to keep the elbow movement or the forearm movement separate from each other the first 2 weeks. But patients will progressively get good strengthening program and range of motion exercises. No, so if you see this patient is actually at 4 months able to already do resistive exercises with dumbbells. No, patient recovered very well and is able to do regular things by now. No, patient's close to a year post-op already. So the last case we'll discuss is acromioclavicular joint dislocation. A lot of times treated non-surgically, but there will be some patients who will be wanting or preferring a surgical option to try to avoid the cosmetic problem that they might see later on. No? So this is our patient around a week after injury. From your x-ray, you can see the gap between the distal clavicle and the acromion. So our procedure here includes using a suture called a fiber tape and another one called fiber wire. No? So the fiber tape, which is a much thicker suture, goes around the coracoid and then enters the distal clavicle and then enters again, no? Going inferiorly to meet the other end to do a knot. No? And then we do suturing technique through both the distal clavicle and the acromion, no? To try to reestablish the acromioclavicular joint. So this is the fiber tape as it's hooking around the coracoid. You can see the fiber wire attached to the distal clavicle into the acromion. And then this is our final product with your fiber tape and your fiber wire suture together. No? So you see a pretty nice approximation of the distal clavicle to the acromion again. So basically that's it. Hope you got a little entertained by the cases that I showed you. No? So these are just some of the techniques that we've developed over the years. Very important to remember, at least for the surgeons out there, the use of the Kessler and the Tajima technique and the bone bridge, which is pretty much a staple for a lot of the implantless techniques that we have, especially for the sports cases. So thank you very much and hope you were slightly entertained. If there'll be any questions, see you later for the Q&A. Thank you very much.
Thank you very much, Dr. Edgar, for a wonderful presentation. Very informative session we had. We have 4 questions here. First question is Achilles tendon exercise. There is a question from Dr. Ahmad Ali Khan. He's asking about Achilles tendon exercises.
What do you mean? Some exercises, I guess, no?
Yeah, I think so,
Yeah.
because the question is not complete.
Right. So basically, obviously, the first part of the strengthening program needs to have isometric exercises first so that there's no risk of overstretching or too much of a forceful concentric contraction. So we do that maybe for 2 weeks before we start the active resistive. And as I showed in the video, we can start active resistive as early as 4 weeks post-op. Then that progresses to weights program wherein they can do heel lifts or tiptoe exercises with dumbbells, progressing to doing it with barbells at a heavier weight as they resume sport-specific exercises. So more or less, it's an additive program starting from an isometric all the way to barbell exercises.
Thank you very much, Doctor. Is there any other questions from the participants? I see only one question here. So if there are no other questions, we move on to the next session. Thank you very much, Dr. Edgar, for your time.
Bye-bye. Thank you.
Thank you. Okay, we move on to our next session. Our next presenter is Ms. Yusufan. She's a known person among Malaysians, especially physiotherapists. So the topic that she's going to deliver is an inevitable encounter: osteoarthritis, knee, aging, and obesity. Ms. Yusufan, to introduce her, she's a physiotherapist. She's a vice chair for World Physiotherapy, Asian Western Pacific Region, WCPT, 2017 to 2021. She is a past president of Malaysian Physiotherapy Association from 2012 to 2019. And then she is a president of Asian Confederation of Physical Therapy from 2016 to 2018. And she also vice president of Confederation of Allied Health Professionals from 2015 to 2019. And she is a certified lymphatic therapist and certified trainer for lymphedema certification. She is a certified Parkinson's wellness recovery therapist. Without further ado, I'd like to pass on the session to Ms. Sufan.
Hello, everyone. Welcome to WCEM 2021. Thank you, Organizing Committee, for allowing me to talk on this topic, an inevitable encounter: osteoarthritis of the knee, aging, and obesity. Now, there can be many causes for knee pain. It could be due to injuries such as torn cartilage, torn ligaments, or torn meniscus, or it could be an infection such as pre-patellar bursitis, patellar tendinitis. It could be wear and tear of the bones such as chondromalacia patella, or iliotibial band syndrome, patellofemoral pain syndrome. Now, all this pain in the knee, if it is not treated properly, eventually will lead to osteoarthritis of the knee. So today we're going to look at osteoarthritis of the knee. Now, the broad definition of osteoarthritis is, it is a degenerative joint disease in which there is a progressive loss of articular cartilage. And when there is loss of articular cartilage, the body will try to repair itself. So it is accompanied by new bone formation and capsular fibrosis. Now, this is another definition. It refers to a clinical syndrome of joint pain accompanied by varying degrees of functional limitations and reduced quality of life. And this definition is more apt for us as rehabilitating patients. Now, the common sites of osteoarthritis are for the neck, the lumbar spine, the hips, the knees, the ankles, and it do affect smaller joints, for example, the finger joints as well. However, the knee is the most common site of osteoarthritis among all the different joints in our body. Now, the risk factors are age. As we grow older, we use the knee more, there will be more wear and tear. Okay? Then it could be due to injuries such as tear ligaments, torn ligaments, okay, or repetitive joint use. can be congenital maldevelopment. For example, a child born with bow legs, and eventually this bow leg will lead to stress on certain parts of the knee joint, leading to early osteoarthritis. Diseases such as rickets or gout, infection like septic arthritis, which actually damage the joint surfaces, and obesity. Obesity is one of the most common risk factors. When we put on weight, we will increase the pressure on the knee joints. And when there is excessive weight, it stresses the knee joint and promote cartilage damage or cartilage fragmentation, leading to wear and tear of the cartilage. Now, we know that if we put on 1 pound of weight, our knee have to carry an excess of 4 pounds due to the pull of gravity. So we have to ensure that obesity is taken care of. The global prevalence of OA is about 5%, and it is projected to increase with the aging population. It affects approximately 10% of men and 13% of women. And OA cases account for 2.5% of years lived with disability. That means if we have OA knee, at the end of our years, 2.5% will be spent in pain, reduced function, or even we have to be wheelchair bound. In 1990, OA knee was in the 10th place in the YLD ladder. However, in 2013, there is an excessive increase by 75%, putting OA knee in the 3rd place in the YLD ladder. Obesity rates are increasing globally, as we know, and it is a strong risk factor for knee OA. The economic burden of OA is very high. It's about US 128 billion taking care of the osteoarthritis. And we know that there is no drugs that can prevent, stop, or even restrain the progression of osteoarthritis. And osteoarthritis limits a person's ability to self-manage other conditions. For example, if you have diabetes and hypertension and you've been told that you have to be very active to do exercises, however, with your OA knee, you will not be able to carry out exercises, and this will increase your mortality rate. The signs and symptoms, pain is number 1. Okay? And you have other long lists, and the most important one is it will eventually lead to deformity, bony hypertrophy, subluxation, loss of range leading to loss of function. That is what we call the disability rate. Before we treat osteoarthritis, we have to do a good assessment of the knee. We can classify our assessment under 4 broad headings. That is, number 1, observe. That means we look. When a patient walks in, we look at his gait. How is he walking? Then we observe his posture. Is he adopting any posture to reduce putting pressure on the affected knee? When the patient is with you, observe the shape of the knee, check the knee for deformities from all angles, from the front, from the lateral aspect, and from the back. Then after that, we palpate or feel the temperature of the joint, tenderness or pain on pressure. Is there any tenderness or pain? Any swelling, any effusion? Next, we will measure and we observe the movement. That is, look at the quality of the movement. Is the movement very smooth, or the movement is affected due to tightness or due to wastings? And then we check the measurement. For example, we check the range of the knee joint. We check or grade the strength of the muscles over the knee joint. And we check for swelling and measure for muscle wasting. We can carry out special tests. For example, some of the tests are valgus and various stress tests, ligament laxity stress, crepitus, patellar tap, and many other tests which is relevant. So the observation, you can see these are the different types of knee that you will see. Like this is a hyperextension with some bony deformities, swelling or fusion here with the patella already obscured by the swelling. And then you have cysts, which is the enlarged cyst here. And this is redness and inflammation, signifying that there could be an acute inflammation of the joint. Then when we observe the leg, we can see that it's a bow leg with the feet in supination, knock knee with the feet in pronation, badly deformed knee with rotation and inequality in leg length. And this is also an inequality in leg length, which will eventually lead to the osteoarthritis of the knee that is most stressed. And this also shows inequality of leg length when we look from the front. So when a patient has a whole knee, we would expect that there will be a lot of wear and tear on the medial aspect of the knee. Now this is a joint, normal joint. The joint space is beautiful, means the cartilage is very smooth and the cartilage is normal. But if you look at this, there is a joint reduced in joint space. That means there is a lot of wear and tear on the medial aspect. So this will give rise to a lot of pain because there is loss of all the soft cartilage and the bones are against each other. Now this is another case of a knock knee. And there is again loss of joint space, especially on the lateral aspect of the knee. And eventually you can see that it will lead to subluxation of this knee when the patient goes into hyperextension and also bow leg at the same time. So when we assess, we have to ask the patient's history, the past and present history. Any physical injuries in the past and now presently, whether it's the same injury that was in the past and now the present, what is the nature of the pain, to describe the pain and to grade the pain, and what was the management or treatment that was given at the past, and also was there any treatment done before coming to see you, and watch out for any limitations or do all the measurements to get the limitations. Now, osteoarthritis knee pain, the gold standard is that the patient should have these 4 criteria, or will describe to you these 4 criteria. There is a deep ache localized in the knee joint. It is aggravated by use and relieved by stress. Patient will complain of stiffness and pain after rest. That means if the patient sits for about an hour, when the patients get up, there will be a lot of stiffness and pain, and it will be relieved by some movement. If our cartilage is aneural, why do we have joint pain? Okay, so the pain actually comes from the nerve endings in the periosteum. We know that the bones are covered by a lining called the periosteum, and these are full of sensory nerve endings. The pain can also come from the microfractures in the subchondral bone, giving us pain, or from the medullary hypertension caused by the distortion of blood flow through the thickened subchondral trabeculae. And also the pain can come from inflammation of the synovium. And we need to know the phases of pain. Pain can be acute pain. That means it is of fast onset, it can be mild to severe, and it just can last for moments or up to weeks. Okay? The old definition is that it should last not longer than 3 to 6 months. But there is a lot of argument, and we found that maybe this is already obsolete. The argument is that when injured tissues repair, inflammation subsides, the pain should go away. If it doesn't go away, then it is no more acute, but to be classified as chronic pain. A chronic pain or persistent long pain will last for more than what is stated in the acute pain. So it should last for more than 12 weeks or than normal healing process. So we can classify chronic pain as 3 to 6 months. And subacute pain is the intermediate vary between acute and chronic pain, and it usually is from 4 to 5 days after the acute injury, lasting up to about 14 days. Now, why is pain, the phases of pain, important for us to know? Because the treatment is different for the doctors and also for the physiotherapists or rehab physicians during each different phase. Also, the pain progress will tell us the progression of the disease or the progression of the treatment. Means if you are treated properly, the pain is going to get less. And also it will tells us if there is any threat or danger if the pain lasts longer than the time stipulated. So when we assess pain, we ask for the site of pain, the severity or intensity, the progression, the character of pain, referred pain, aggravating factors, relieving factors, time and mode of onset, differences during the day and differences during the season, because all these will tell us something. That means when we ask all these things, we will be able to characterize the pain. We will be able to infer the pathophysiology of the pain and also to evaluate the physical and psychosocial comorbidities. Then we can assess the degree and nature of disability, and finally to develop a therapeutic strategy for the treatment of pain. Now, pain can be recorded in many ways, and usually we will use the numeric scale or the visual analog scale. It means the patient will be told that 0 is no pain and 10 is severe pain. That means you'll be crying in pain, and the patient can just point out to you where is his pain, or we can use the face to describe the pain. Usually for children, it is easy to use this. That means smiling means there is no pain, and crying means that there is a lot of pain. The McGill Pain Index chart, not for normal people, because we will not be able to tell what is phantom limb pain or childbirth pain. Not everybody can tell that. The Mansky Pain Scale, like a typical VAS, but it's a little different in the sense that it explains how the medication works or it doesn't work, okay? The color scale is easy. Cold means there is no pain at all, and hot means it's burning, there's a lot of pain, okay? And behavioral observations, this is what we observe every day in our patients. Body movements, facial expression, and muscle tension. The global pain scale is very unique as it focuses on the physical pain and how this pain affects the patient's life and ADL. Current pain levels, the emotional well-being, clinical outcomes, and engagement in ADL is all observed in this global pain scale. Now, pain assessment, what do they tell? The type of pain. Now, if a patient tells you that it's an aching pain, we know that it's the degenerative changes, the periosteal elevation due to the raised intraosseous pressure. And if the patient says that it's a sharp catching pain, we know it's a mechanical problem. Now, in arthritic pain, we know that there will be stiffness and it eases with movement. Pain at rest, it is definitely not a mechanical pain, and we know that there is some inflammation because when it's resting, the pain is still persistent. That means there is inflammation of the synovium and also the periarticular tissue. And also there can be pain which causes protective muscle spasm. Now, pain during friction, that means there is bony friction and also patellar tracking. Pain after activity, again, when you're resting and you find that the knee is throbbing, then it could be infection in the knee joint. Pain around the knee can be ligaments. When you palpate, can be the ligaments or can be the muscles. And constant pain, irrespective of activity or even after taking strong analgesia, it is a red flag. We have to be careful. Could there be a growth or could that be a nerve affected? Now, clinical reasons why some more joints are more prone to wear and tear of the knee joints. It is found that there will be increased water in the articular cartilage. The changes in the quality of collagen fibers will increase the diameter and disrupt the collagen fibers. At molecular level, there will be loss of proteoglycans in the cartilage and the lesions appear. That means the proteoglycans is the jelly-like substance that is found in the cartilage. And obesity and repeated use, that means the grinding will lead to fibrillation of the cartilage, leading to osteoarthritis of the knee. Now, grinding will lead to subchondral bone becoming urbaneated. Then the non-margins hypertrophies will form osteophytes, loose flakes of cartilage inside synovial membrane inflammation, leading to capsular thickening. Now, this is a knee chart that we can use when we measure the knee. You divide the knee into different quadrants and you will note down particularly the pain and the deformity that is observed in all these quadrants. So this is the anterior knee and this is the posterior knee. Okay? So you can see that the lateral aspect of the knee, there is narrowing of joint space due to friction. For example, if this is a knock knee patient, you find that only lateral aspect is narrowing of joint space, and you can confirm with the X-ray measurement. Next one is observation of the gait. Limb, for example, if the patient is limping, that means the patient is weight bearing more on the good side to avoid weight bearing on the affected knee. The stance phase, watch for any fixed flexion deformity. Usually the patient will have about 25% degrees of flexion due to many different reasons. We will look at it later. Now, the swing phase is the patient walking with the normal phases of gait, or is the patient moving with the hip fixed, with the knee fixed, but the movement only occurring at the hip. That means swing the leg as a piece due to pain in the joint. And watch out for triple displacement. That means that's flexion, posterior subluxation, and lateral rotation of the tibia, because there is a lot of contraction of the hamstring. Then palpate for local rise in temperature and warmth. Usually in OA cases, there is no warmth, but there is inflammation, there will be warmth. Pain or tenderness along the joint line will indicate injury to the ligaments, meniscus, or fat pad. Tenderness over the tibia tubercle will indicate patella, ligament strain or stress, and also avulsion. Tenderness when displace the patella in any 4 directions with pressure applied will give us the impression of chondromalacia patella. That means we put pressure on the patella and we move upwards, downwards, side to side, and the patient will complain of pain when pressure is applied. Now we can do patellar tap for effusion, and we can do pressure on the patella in the 4 directions. This is a picture to show how it's done. Now, range of motion is usually measured using a goniometer, and the normal knee range is from 0 to about 140, give and take. If you have fat or big gastrocnemius, then you would expect that the range of flexion will be a little bit less. When doing the range motion, apply overpressure and note the pain and the end feel. The end feel means how do you feel? Is it a springy block that will imply that is the tendon or meniscus, or is it a rigid block that will imply that there is some bony block? Okay, and watch out for capsular restriction pattern. That means which compartment is more tight than the other compartment. Now, measurement, usually you will have to compare to the good knee. Unless there is both knees are affected, then you will do 2 different knees for the OA. Now, watch out for wasting. Wasting indicates disuse or reduced range of motion. That means the patient is not moving in the particular range and cause wasting of that particular muscle. So swelling, that means there is effusion or inflammation, and muscle strength. If it is low muscle strength, it will indicate there is reduced activity or there is deconditioning. So this is the measurement that is usually done mid-patellar. Now, if this is a huge swelling, you will find that this measurement will definitely increase. So mid-patellar is, or joint line is usually to measure swelling of the knee joint. And 5 centimeters above the upper pole of the patella is to indicate whether there is any wasting of the VMO muscles. 10 centimeters will indicate whether there is wasting of the quadriceps, and 15 centimeters will indicate whether there is wasting of the hamstring. So the measurement is done. We come to the range of movement. Again, assessment is for bilateral comparison. We do the active range, then the active range with overpressure, the passive range. Then we check for lateral displacement, that is the valgus and the various tests to check for joint instability and soft tissue laxity. And also the end view is important, just mentioned before, and check whether the movement is limited by pain, limited by weakness, or limited by tightness. And all these can be confirmed with ROM. Now, the Kellgren and Lawrence grading system of OA knee is that grade 0, it is normal, and grade 4, there are large osteophytes, marked narrowing, severe sclerosis, and definite deformity of the bone ends. Now, usually for us as a physical therapist, when a patient comes to us with a grade 4, we will always refer the patient back to the orthopedic surgeon, because the patient will definitely need total knee replacement. And we will do the preparation for the total knee once the surgeon explains to the patient that she has to undergo total knee replacement. If a patient is grade 4 and you try to treat the patient, you find that the patient keeps coming to you and the treatment results is not good. So the finally, the diagnosis of OA knee is knee pain is definitely there, and at least 3 out of the 6 characteristics stated below. That means the patient should be more than 50 years old. Not always, but this is generally. Morning stiffness, and after some minutes of exercises, the pain goes off. There will be crepitation. There will be bony tenderness, bony enlargement, and usually OA knee, there is no palpable warmth unless there is a recent acute inflammation of the joint. So this is the classical clinical criteria established by ACR in 1981. The sensitivity is 95% and specificity is 69%. So next we come to the conservative management. We're not going to talk about other management. Okay, conservative management will be pain control with medication, physiotherapy, and others such as the use of adjuncts, good practice, joint protection, and education. So today, I'm only going to talk about physiotherapy with exercise alone. We use exercise to reduce pain, to increase range of movement, increase strength, and to stabilize the joint. Now, exercises will be different in the depending on the condition of the patient. For example, in acute painful episodes, the exercise will be mostly isometric exercise with no or little movements to prevent aggravating the pain, and low impact during exercise. Usually, we will prescribe non-weight bearing, that is open chain kinetics, and partial weight bearing closed chain kinetics. Now, during the less painful episodes, we will add progressive muscle strengthening exercise. Now, quadriceps impairment is usually associated with increased pain and greater deterioration in the function over time. Quads exercise is the cornerstone. Therefore, we concentrate a lot on quads exercise to prevent deterioration of the OA knee. And quads exercise also resists the ADD, adduction movement. That means it will prevent the bow leg event from happening. Now, strong quads can, if up to 64%, reduce the risk of developing OA hip or knee. And these are mostly weight-bearing exercise. Now, hamstring exercise is used to control the various and valgus laxity together with co-contraction of the quadriceps. Strong hamstring causes less damage, will prevent less damage to the knee. Hip abductor will reduce the knee load, and strengthening the adductor will resist the femur to move into the various positions. So it is important that when you assess the patient, you will watch out what are the muscles you want to strengthen or what are the exercises you want to teach. And stretching exercises will be for the hip flexor because they will adopt the flexion posture. Stretch the hamstring, the calf, and this is all to prevent the 20 degrees hip flexion gait. So these are some of the examples of exercises that we will have to watch out for. For example, the hip flexors, they will become very tight and short. For example, in this case is a bow-legged OA, and the weak muscles will be the abductors and the extensors. So where you have to stretch the flexors, you have to strengthen the abductors and the extensors. And the knee, medial hamstring, and the quadriceps will become tight. So we have to stretch the lateral hamstring will become weak, the VMO will become weak. So we have to stretch we have to strengthen these muscles and stretch these muscles. In the ankle, you find that the gastrocnemius medial head will become short or tight, and the gastrocnemius, the lateral head, will be weakened. So strengthen the weak muscles and stretch the tight muscles. And sometimes you have to stretch and strengthen the tight muscles. Now, other physiotherapy methods that can be used, just mentioned on passing by, are prescription of orthosis and walking aids, gait training, proper footwear, electrotherapy, hydrotherapy, manual therapy, and taping. These are some that can be used. So thank you very much for listening to this topic. Now, just to mention, those who think they have no time for bodily exercise will sooner or later have to find time for illness, according to British Prime Minister Edward Stanley. Thank you very much.
Thank you very much, Madam Yu Sufan. For the participants who have questions, actually, Madam Sufan is not around. So in the chat box, we have given her email address. So you can send in your questions to her directly. She's kind enough. She will answer all the questions with patience. So we have completed the symposia until now. So we move on to the abstract presentations now. For the abstract presentation.
Hi, good day everyone. I'm Anandi Subramaniam, sport therapist from Rehabilitation Therapy. Today I'm going to present about my research topic, prevalence of musculoskeletal injury among Malaysian para-athletics athletes. As an introduction, disabled sports or para sports exist since more than 100 years ago. Disabled sports are developed based on existing able-bodied sports. Disabled sports in Malaysia started in 1970, and early sports played are basketball, table tennis, badminton, darts, and carom. In para-athletic event, it divided into two, which are the track event and field event. Based on para-athletic classification, people with physical, vision, and intellectual disability are eligible to compete in this sport. These are the categories of para-athletics. So T stands for track and jump, while F stands for field. So the categories are visual impairment, intellectual impairment, cerebral palsy, short stature, lower limb amputation, and upper limb amputation. Problem statement. Sports injury may cause more negative consequence among disabled athlete in comparison with normal athlete. sports injury can also lead to morbidity and mortality. Lee 2015 said that sports injury can also lead to academic burden for the society. Lack of previous research on identifying the characteristic and incidence of sport-related injuries among Malaysian para-athletics athletes. The aim of this study to identify the musculoskeletal injury prevalence among Malaysian para-athletics athletes. Research objective is to investigate the type of injuries and to identify the body part involved in sports injury among Malaysian para-athletics athletes and to identify the perceived risk factor of sports injury among Malaysian para-athletics athletes. Research question to find out what are the type of sports injuries and which body part involved in sports injury that perceived by our para-athletics athlete, and also to find out the risk factor that may have influenced the sport injury. The design is descriptive epidemiological design study used to summarize the distribution of musculoskeletal injury among Malaysian para-athletics athletes. A questionnaire has been distributed among Malaysian para-athletics athletes to obtain information such as type of injury, the body part that frequently get injured, and the risk factor they may have caused the injury to occur. Sampling methods are critical sample, consists of Malaysian para-athletics athletes because they are difficult to gather. And they were 30 athletes from Paralympic Excellence Center, Paralympic Center of Excellence, Kampong Pandan, voluntarily took part in this study. The inclusion criteria that require for the athlete to take part in this study are: participant must be a national or international level Malaysian para-athletics athlete. Participant must be presented with at least one disability. And also they must have experienced at least one major musculoskeletal injury in the past 12 months. The instrument used is questionnaire, where in section A, the personal information has been obtained is including their demographic data and also their disability. In section B, the injury details were obtained where the type of injury, injured body part, risk factor, and type of treatment received and duration of recovery were obtained. The study procedure: before the questionnaire distributed to the athlete, preliminary survey were done among students from UPSI and obtained permission from our Faculty of Sports Science from UPSI, and also obtained permission from head coach of Malaysian Paralympic Council. And during the study, I explained the purpose of the research and briefed to all the athletes what will be the outcome of this study. And before they start answering the questionnaire, they were required to sign the consent form and they were given 40 minutes to answer. For athletes with visual impairment and intellectual disability, face-to-face interview were done by myself, and it took about 30 to 40 minutes. After the data collection done, data has been processed and analyzed using SPSS, and frequency and percentage used to analyze the independent variable. Demographic data: they were 21 male participants and 9 female participants take part in this study. And the second table explain the year of involvement in sport by those athletes. So it shows that they were majorly the athlete from 1 year to 9 year participant, but they are from national and international level. So it means that they compete in SEA Games, either SEA Games, Commonwealth or Olympics. Result: type of injury, it say that our founding found out that muscle strain is the most commonest injury, while others explains the laceration, abrasion, contusion, or nerve injury. The body part that frequently get injured is lower limb. It very much makes sense as these athletes are taking part in athletics. For lower limb, the most commonest body part to get injured with 24% each, which is the posterior thigh and ankle, carries the highest, and followed by the lumbosacral joint. For upper limb, shoulder carries the highest percentage of injury with 40%, and the rest of the joints carry equally 15% of the injury. The possible risk factor, either extrinsic or intrinsic, so the study shows that intrinsic factor is the most influencing factor for them to get injury. As for discussion, the present study shows that soft tissue injury accounted more number of percentage of injury. The soft tissue injuries such as strain, sprain, abrasion, laceration, or nerve-related injury, and more. Present study also found that strain is the commonest type of injury among Malaysian para-athletics athletes. Lee 2015 also supported the finding, where she also found that soft tissue injury were commonly reported among para-athletes with disability. Another study by Baufin 2015 as well found that muscle strain were the commonest injury to happen among the para-athletics athletes. Current study shows that lower extremity contributed the higher rate of injury among Malaysian para-athletics. To be specific, posterior thigh and ankle was the commonest body part to get injured among our para-athletics athletes. This study reported that least injury of upper extremity and shoulder was the commonest body part to get injured. In study done by Lee 2015, also stated that lower extremity was the commonest area to get injured. Blower 2016 also specifically stated that thigh was the commonest anatomic region injured in ambulant athlete, which is the normal athlete. Blower also supported the finding of upper extremity reported the least injury, and shoulder or clavicle is common anatomic location to get injured. Intrinsic factor shows the higher percentage in causing injury to para-athletics in comparison with the extrinsic factor, as referring to the pie chart earlier. The athletes are reported 25% injury occurred to self-induced, where they themselves induced the injury, and 90% of the injury due to their own disability, and 17% of injury occurred due to the previous injury, and another 6% injury occurred due to their health status on that day of participation and physical fitness respectively. This finding has been supported by Vital 2007, where intrinsic factors such as strength, balance, coordination, flexibility, and anatomic alignment that as causes the injury to occur, and it lead to the overuse of segment, which may have contributed recurrent injury. Vital 2007 also found that Paralympic track and field is characterized by the lack of physical contact among competitors. The modality marks such as J-leg, which is directly influenced over the athlete biomechanics, which favor the occurrence of high number of injuries. As a conclusion, the study found that soft tissue injury, which is strain, are the most common injury among our para-athletics athletes, and lower extremity contributed the high number of injury. In addition, intrinsic factor causes the higher rate of injury occurrence, which directly correlated with the nature of sports itself. To the sport-specific finding can inform the physician, therapist, athletic trainer, and coaches regarding the injury occurrence and help in design the injury prevention strategies. Further studies which identify the prevention strategies should be carried out. And in addition to that, the relationship between the prevalence of injury and the classification of the athlete is needed, because the current study didn't go according to the classification. It has been conducted in general. So these are the reference used. And that is all from me. Thank you so much.
Thank you very much, Ms. Anandi. That was a good presentation. Any questions from the floor? We don't have any questions at the moment. Anyhow, give me a second. There is a question. Okay. Normal athletes may be having problems with muscular imbalance, but for para athletes, is they have any muscle imbalance too?
Hi everyone, thank you for the question. I'm assuming there will be a muscle imbalance, especially where there is athlete with short stature or even CP participant. That I'm sorry, my battery is full. So hence why the training will be mostly one-sided, which will be on the strength side. But anyway, my study is not conducted based on the muscular imbalance. It's just to find out the injury prevalence alone. I think I answered the question.
Yeah, thank you. Thank you. Yeah, to add up with Ms. Anandi, yes, muscle imbalance will be there in para athletes also. So when we are treating the para athletes, we will be actually focusing on muscle imbalance correction as well. Okay, thank you, Ms. Anandi. So we move forward to our next abstract presenter. Our next abstract presenter is Ms. Yanling Yu from China. The topic for her presentation, is a cross-sectional study of gender differences in physical activity related injuries among Chinese students in rehabilitation.
Hello experts and colleagues. I am a graduate student in sports rehabilitation at Shanghai University of Sports. It's an honor to speak as the abstract presenter during the conference. The title of my research is Prevalence and Risk Factors of Physical Activity-Related Injuries amongst Chinese university students majoring in rehabilitation, a cross-sectional study. I will describe my research in the following 6 sections. First, the background sections. Let's first look at what the definitions of physical activity and physical activity-related injuries are. PA is any form or manner of physical movement that is performed by contracting skeletal muscles and requires the expenditure of energy. PARI is defined as any injury, such as sprain, strain, and fracture, suffered in the process of participating in PA or leisure time. Then comes the research background of this study. PA could reduce the risk of chronic non-communicable illnesses. For the moment, studies on physical activity have reached different conclusions. 25% of adults and 81% of teens worldwide are not physically active. A global study showed that the percentage of inactivity among college students was about 41.4%. Global promotion of physical activities has an associated risk of injury. PARI can be prevented and controlled. Therefore, PARI prevention should be on the agenda of PA promotion. According to the prevention sequence model, the relevant characteristics of PARI in the target population should be described first. The purpose of this study was to further understand the details of PARI in the college student population in rehabilitation. The entire research process is described next. We developed the questionnaire from April to June 2020. From July to September, we did a pre-survey. From October 2020 to January 2021, we conducted a nationwide electronic questionnaire. The written rate was 100% and 32 valid questionnaires were obtained. All data were collected using a structured questionnaire that collected basic demographic information, PA level, number of injuries in the last 12 months, and their characteristics. This is the statistical method used in this study. Next are the results of this study. For the demographic characteristics of PARI, statistically significant differences were found in terms of gender, place of birth, being an only child, being a member of a sports team, region, BMI grouping, and annual per capita household income. As shown in this table, all students in grades 1 to 4 participated in this study, with an average age of 90.82 years. The survey revealed 792 total injuries. As indicated in the table, the most reported site of injury was the ankle, foot, too, accounting for 29.6% of the total number of injuries. Multiple sites of injury were reported by 27.2%. Of the injured university students, the cumulative frequency of injury categories was 1095, with muscle and tendon injuries being the most prevalent of all injury categories, accounting for 48.7% of the total number of injuries. 249 didn't treat their injuries afterwards, whilst the other 543 had specific treatments as shown in the table. Next is the discussion section. The incidence of PARI in the current investigation was 30.1%, which was significantly lower than the previous study. Over 50% of the main areas were in the lower limbs. Nearly 86% of the PARI types were muscle, tendon, strings or springs, ligaments or joint capsules. Males had higher total PA levels and lower rates of low PA levels than females. Males prefer recreational exercise activities than females, which involve high velocity contact, jumping, sprinting, and spying. There are some limitations in this study. Firstly, the cross-sectional study has some limitations, as it is heavily dependent on the participants' responses and memory, resulting in a loss of information that may affect the results of this study to some extent. But self-reporting is the most practical and cost-effective method. Further research will be carried out by the author's team to avoid these limitations and form a good representation of PARI in the general college population. Due to the large population in China, PARI is an important public health problem among Chinese university students. While active physical activity is promoted, The related injuries should not be ignored. Significant differences were found in some injury characteristics between males and females. More research should be conducted to develop good injury perceptions in the general university population, which is important to develop effective prevention interventions for at-risk populations to better reduce PARI and promote positive. That's the end of my speech. Thank you all.
Thank you very much, Ms. Yan Ling. We are running out of time, so we proceed with our next abstract presenter. The next abstract presenter for today's session is Dr. Rukhia Begum from Pakistan. Her topic of presentation is effects of mecanal taping on quadriceps angle and intensity of pain in females with patellofemoral pain syndrome. Without further ado, I would like to pass on the session to Dr. Rukhia Begum.
Bismillahirrahmanirrahim. Assalamu alaikum. Hello everyone. I am Dr. Rukhia Begum, orthopedic manual physical therapist from Foundation University Institute of Rehabilitation Sciences, Pakistan. Topic for my presentation is effects of mecanal taping on quadriceps angle and intensity of the pain in females with patellofemoral pain syndrome. Let's start with introduction. Tightness of the rectus femoris, tight irritable pain, tightness of the distal animus, and increased screw angle. All these factors are contributing for anterior knee pain or pain behind the patella. This is known as patellofemoral pain syndrome, which contributes almost 30 to 40% of all sports medicine results. There are multiple treatments for patellofemoral pain syndrome. Patellar taping is one of them. Epidemiology. 15 to 45% in the United States reports patellofemoral pain syndrome, out of which 28.9% are adolescents, 13.5% are in military population, and 22.7% are female. Martin Whitingham reports that combination of daily patellar taping and exercise was successful in improving pain and quality of life in patients with patellofemoral pain syndrome. Bain et al. Conducted a study in patients with patellofemoral pain syndrome in which they find significant decline in the intensity of the pain after the application of mecanal tape. Significance of the study. This study will help the practitioner to use the best treatment option for the patients with patellofemoral pain syndrome. Objective of the study: to determine the effects of mecanal taping combined with strengthening exercises of vastus medialis oblique in females with patellofemoral pain syndrome. Null hypothesis: there is no difference in the effect of mecanal taping on quadriceps angle and intensity of the pain in female with patellofemoral pain syndrome. Study or alternate hypothesis: there is a difference in the effect of mecanal taping on quadriceps angle and intensity of the pain in females with patellofemoral pain syndrome. Materials and methods. The study setting was Koji Foundation Hospital, Rawalpindi, Islamabad, Pakistan. Study design was randomized controlled trial. Sampling technique was convenient sampling technique with randomization. Duration of the study was 6 months from January 2018 to June 2018. Sample size was 40. Sample selection criteria include diagnosed cases of patellofemoral pain syndrome between the age of 25 to 45 years, limited range of motion at the knee joint, difficulty in the following activities such as walk, squat, and kneeling. Exclusion criteria included history of OA knee, patellar dislocation, any systemic disease, any history of knee surgery. Ethical consideration was taken from the Foundation University, Koji Foundation Hospital, Rawalpindi, Pakistan. Consent was taken on patients and confidentiality of the participants was maintained. Data collection tools were lower extremity function index, numeric pain rating scale, and goniometry. Total approached cases were 70, out of which 22 patients didn't fulfill the inclusion criteria and 48 patients were included in the study, out of which 24 in group A and 24 in group B. From 48 patients, 8 patients were dropped out From group A, 5, and group B, 3 patients were dropped out. 40 patients were included in the study and were analyzed at the end of the study. Interventions. In the control group, TENS was used for 15 minutes with cyclic time continuous. Frequency was used for 50 to 100 Hz. Hot page for 15 minutes. Strengthening exercises of vastus medialis oblique include sling open kinetic chain exercises and sling closed kinetic chain exercises. Quad isometric strengthening stretching exercises for tight hamstring and stretching exercises of tight adductors were also used. In experimental group, additional McConnell tape was used in which a tape roll-over tape almost 15 centimeters in size was directly applied over the skin, on which 12 centimeter rigid tape was applied, starting from lateral epicondyle of the humerus, anchored the patella and end on the posterior aspect of the knee was utilized. Data was analyzed by using SPSS volume 21 results. Results of the study showed a mean age of the participants in the control group was 36.85 and in experimental group was 35.23. Main U test was used for comparison between the groups, in which shows a significant improvement in the Q angle and numeric pain rating scale in experimental group as compared to control group. The p-value was less than 0.05. Knee range of motion, flexion and extension were both improved in both experimental group. Discussion. In the current study, post-treatment score of numeric pain rating scale for this group showed significant reduction in pain intensity. P-value was less than 0.05. The results of the current study are supported by the study conducted in 2012 by Selectus DB et al., in which he finds significant improvement in pain. This study also reveals that McConnell taping is effective in improving lower extremity function index as well as in Q angle and knee flexion range of motion. The p-value was less than 0.05. It is quoted by Campbell et al. In 2012, in which they find a significant improvement in pain intensity as well as lower extremity function status. Conclusion: the current study concluded that McConnell taping combined with strengthening exercises of vastus medialis oblique is more effective in reducing pain and intensity and decrease in Q angle in females with patellofemoral pain syndrome. Limitation of the study was included high cost McConnell tape was a major limitation. The data was collected from single setting and diversity was not achieved. Recommendation: EMG studies should be conducted in future. Multiple setting and both genders should be included in future studies. Acknowledgement: special thanks to Dr. Furqan Ahmed Siddiqui, Principal at UIRS, for his motivation and sports in this project. References. Here's my contact. Thank you.
Thank you very much, Dr. Rukhia. So we proceed with our next presenter. Our next presenter is Mr. Solayan Rajan Chellappa from India. His topic of presentation is effects of mHealth app-based intervention in relapsing multiple sclerosis, a mixed methods, pragmatic randomized control trial study protocol. I would like to welcome Mr. Solayan to take over.
Respected dignitaries and organizers, I thank all of you for giving this opportunity to present my study protocol in this conference. Myself, Solayan Rajan Chellappa, physiotherapist, Department of PRM, PGA-MER, Chandigarh, India. The title of this study protocol is The Effect of Mobile Health Application-Based Intervention in Relapsing Multiple Sclerosis, a Mixed Method Pragmatic Randomized Control Trial. Introduction. The multiple sclerosis is a chronic immune-mediated inflammatory demyelinating disorder of the central nervous system and is the most common non-traumatic cause of chronic neurological disability in young adults. The global burden of MS has been estimated to be of 2 million cases were diagnosed in 2016. In India, a rough estimated prevalence of 5 to 10 per 1 lakh individuals. Due to its chronic progressive nature of the disease and associated neurological disability, individuals with MS require uninterrupted rehabilitation and constant monitoring to maintain quality of life. Therefore, delaying or slowing a functional loss becomes a valuable goal and mainstay of management. The routine rehabilitation practice of MS, individuals with MS are usually instructed to perform exercises regularly as recommended by the physiotherapist and issued a written protocol for self-management. Depending on the progression, the individuals are advised to revisit the hospital for exercise modification. However, the compliance to home exercise program is a challenge and they often return when their condition deteriorates. Limitations of routine rehabilitation practices are lack of constant caregiver, forgetting the steps of rehabilitation, lack of locally available MS experts, internal barriers and external barriers. All these factors pose a significant challenges for delivering the routine MS care, especially adherence to exercise rehabilitation. Therefore, a self-management and remote monitoring of individuals with MS may be a viable solution for rehabilitation of MS. The need of the study to overcome the barriers of routine rehabilitation practices and easily accessible and available technology-based solutions like mobile health application can be adapted for providing tele-rehabilitation and monitoring. The most of the mHealth app for exercise rehabilitation described in the literature are at various stages of development and most lack validation studies. The systematic review of mobile health application market and literature found that existing MS app may not meet the demands of patients with MS. Moreover, in the COVID-19 pandemic, avoidance of physical contact is paramount, and it is preferable that patients are guided for exercises in their home environment, which also achieves the goal of distancing. The objective of the study, considering the above facts regarding the barriers and challenges associated with the routine rehab practice of MS, we planned the current study with the objective to develop a mobile health application and evaluate its clinical and cost effectiveness as a service delivery model for providing exercise rehabilitation in relapsing MS. The REMIT MS trial 1 and 2 will be a mixed method and pragmatic open label pilot study on individuals with the relapsing MS. The overview of REMIT MS trial. The trial overview. This trial will be conducted in 2 phases, the phase 1 and development and piloting of mobile health application, the phase 2 evaluation of clinical and cost effectiveness of REMIT MS application for exercise rehabilitation of individuals with a relapsing MS. Methodology of phase 1. The phase 1 will be carried out in 2 sub-phases, that is preliminary phase to develop a app content and pilot phase is to assess the user friendliness and design of the final MS application. To achieve the above objective, we propose a 3-step process such as the step 1 assessment of problem related to health and rehabilitation practices faced by individuals with a relapsing MS. The step 2 review of literature. The step 3 is expert guidance. So on the basis of the results of step 1, 2 and 3, the app content will be developed. The app content would mainly focus on patient education and self-management information in an audio-visual format. The validity of the preliminary app content will be assessed by experts in the field of MS rehabilitation. As per the expert opinion, the modification in the content will be made. At the end of the preliminary phase, the provisional app content will be created for pilot phase. The pilot study will be carried out on a small group of individuals with a relapsing MS meeting the selection criteria for a period of 1 month and to assess the quality, interface, and functionality. Based on the feedback, additional modifications will be made in the content, and final version of the health application will be developed for clinical and cost effectiveness. The following features will be present in the app content: the information provision about the MS, video demonstration with audio for the exercises, audio explanation for the fatigue management, and exercise recording option, motivational statement, and exercise diary. Methodology of phase 2. The objective of the phase 2 is to evaluate the clinical and cost effectiveness of REMIT MS app-based exercise rehabilitation for the individuals with a relapsing MS. The probe design will be followed. The study will be conducted in a MS clinic, Department of Neurology, PGIMH, Chandigarh. The following inclusion criteria will be used: the individuals with the relapsing MS and age between 18 to 50 years of both genders. EDSS ranges from 1 to 5. The clinically stable or relapse-free for past 1 month before the recruitment. MMSE score more than 24. Individuals who are willing to sign the informed consent, and individuals must have a smartphone with the internet facility and should be competent as well as willing to use mobile health application as a healthcare tool. The sample size total of 55 subjects would be required in each arm to show a difference of 10 points in overall quality of life between the groups at 80% power and 5% significant level. Considering a 20% attrition rate, actually 110 subjects, that is 55 subjects in each arm. The block randomization and allocation concealment will be done using the envelope method for the eligible subjects. Experimental group subjects will be allocated for mobile health application, and control group subjects will be allocated for routine care group. At the baseline in both groups will be assessed for the primary and secondary outcome measures by the blended assessor. The follow-up assessment will be done at 3rd and 6 months of recruitment. The treatment interventions. The 2 home-based treatment will be investigated in the study over a period of 6 months. The both groups will be advised to carry out similar exercise rehabilitation measures that depend on their health issues for at least 5 days a week for 6 months. Treatment comparison. The routine care group will receive exercise flyer handout. The handout will describe the exercise steps with pictures. The subjects will be advised to maintain a diary for documentation of exercise regimen. No restriction for hospital revisits for the purpose of exercise modification. The Remit MS based exercise group subjects will receive the mobile health application. The app will contain an audio visual demonstration to perform the exercises and will also provide the way of progression of the exercise regimen. The app will be linked to be a administrative module for monitoring. The subjects will be advised to follow the Remit MS app based exercise rehabilitation, and any queries regarding the exercise will be sorted out via interaction facility with the investigator to avoid frequent hospital revisits. The outcome measures. Following outcome measures will be measured during the baseline, post-intervention at 3rd and 6 months recruitment, which will be assessed by an independent assessor blinded to randomization and group allocation. The statistical methods. The descriptive statistics will be calculated for the socio-demographic, clinical and rehabilitation baseline outcome measures. The chi-square test, ANPAT-T test, or Mann-Whitney U test to check the between group difference in outcomes. The multivariable logistic analysis to assess the adjusted effect of M-Health application-based exercise rehabilitation intervention on improving QOL, and the effects will be presented as unadjusted and adjusted risk ratios. The p-value less than 0.05 considered as a statistically significant. The discussion. The M-Health app is anticipated to be an effective service delivery model for individuals with MS, which may lead to improved QOL, better adherence of home exercise program, and maintaining or improving physical and cognitive function. It could therefore possibly lead to a reduction in the burden of chronic progressive nature of this disease. The finding of this proposed trial may provide a tele-rehabilitation platform for individuals with MS, help to establish a healthcare delivery model, and reduce the healthcare expenditure. In addition, the results of this research would increase the scope of mobile health in other chronic diseases and open a new vista of healthcare delivery in India and other resource-limited settings. The trial was registered on CTRI in the year of 2019. The trial has been approved by the Institutional Ethical Review Board of Punjab University, Patellar, and PGIMR, Chandigarh, India. Currently, we are recruiting for phase 1 of the study. The process was started in April 2021. The patient recruitment phase is estimated to be completed by 30th of September 2021. Thank you.
Thank you very much, Mr. Solayan. Is there any questions for him? Okay. No further questions. So thank you very much. So we move on to our next abstract presenter. So our next abstract presenter is Our next abstract presenter is Dr. Arun Balasubramaniam from India. His topic of presentation is effect of motor control exercises versus proprioceptive neuromuscular facilitation on chronic low back pain. Without further ado, I would like to welcome Dr. Arun to take over the session.
Very good morning to one and all the judges, respected dignitaries. I am Dr. B. Arun, physiotherapist from E-Road Government Hospital, Tamil Nadu, India. Today I am going to present my research paper to the extensive International World Congress. So my topic is effect of motor control exercises versus proprioceptive neuromuscular facilitation on chronic low back pain. Chronic low back pain is becoming increasing problematic in the past centuries. It is an epidemic in the 21st century. It is also called as 21st healthcare disaster. 80% of the people at some point of time experiences low back pain in their life. 90% are usually an unidentifiable causes. When we look at the statistics of the back pain ranks number 1 among all musculoskeletal problems. It ranks number 2 in the common reason for the doctor's visit. It ranks number 3 for the common reason for the surgery. And it ranks number 5 for the common reason for the admission. And when we look at the biomechanics of mechanical low back pain, a mechanical low back pain doesn't have any precise causes. So the back pain occurs because of mechanical malformation in the body. Like a low back pain occurs because of weak core muscles, and these core muscles are weakened when the person tries to do any excessive activity which causes muscle fatigue. This muscle fatigue may result in pain, and the pain results in spasm. And the spasm also affects the weak core muscles, and the core muscles become weakened, and this muscle spasm also rise to the low back pain, and the pain, it's a pain spasm pain cycle actually. Most of the causes of the low back pain are due to the muscular problems. Postural control deficits affects daily functional activities as it requires the integration of appropriate level of proprioception and the muscle strength. Chronic low back pain increases the postural sway due to reduction in the function and coordination of the stabilization of the lumbar muscles. All these researches was conducted by the Gribble and Hodges in 2004 and 1998 respectively. Multiple interventions are claimed to be effective in the management of low back pain, but most of the exercises are still under discussion. And motor control exercise is a popular form of exercises in recent 2 decades, and still there are a lot of researches conducted on the motor control exercises to find out its efficacy. Motor control exercises restores the coordinated and efficient use of the muscle that controls and supports the spine. It focuses on the activation of the deep trunk muscles and progress more complex functional tasks integrating to the deep as well as the global muscles. And when we look at the PNF, that is proprioceptive neuromuscular facilitation exercises, which are commonly used in the stroke patients or the neurological conditions. The purpose of the PNF is to encourage the coordination, enhances the movement of the joints, and also movement control in the lumbar spine. Most of the literature supports that the compromise of the balance is due to weakness of the muscles in the low back pain. However, studies focusing on the rehabilitation, on the balance, or the postural control are limited. So this is the type of study which helps to compare the PNF therapy as well as the motor control exercises with the low back pain. And there are a lot of studies are not done in this, and there is no extensive research conducted. So the purpose of the study is to compare the effect of motor control exercises versus PNF on chronic low back pain. And my study objectives are to find out the effect of motor control exercises on balance and disability, to find the effect of PNF on dynamic balance and functional disability, and to compare whether which is good, either this motor control or the PNF. And my hypothesis states that there will be no significant, my null hypothesis, there is no significant difference between motor control exercises versus PNF on chronic low back pain. So this is my study methodology. I am conducting a randomized control trials, and this study was happened in the government headquarters hospital, E-Road, Tamil Nadu, India, and all the samples are convenient sampling method. I have selected 45 patients with the low back pain based on the selection criteria, which is we are going to see later. And I have 3 groups, 15 patients in each group. And these are the selection criteria. Based on this only, we are included all the participants, age group of 25 to 40 years, both genders, postural or mechanical low back pain for more than 3 months, And the pain in the used in the visual analog scale, 10 centimeter visual analog scale is 6, that is moderate pain, as well as moderate disability, which is measured by Osteoarthritis Disability Index. Patient who has radiating pain or diabetic or hypertensive, any recent injury in the spine or the lumbar or in the lower limbs were not included. As well as psychologically, patients were not included. The outcome measures are dynamic balance, functional disability. Dynamic balance was measured using star excursion balance test, and the functional disability was assessed using Osteoarthritis Disability Index. Both the SCBT and ODA has got high reliability and validity. And all the participants were divided randomly into 3 groups using a computer-assisted randomization. Group 1 has got motor control exercises, group 2 is PNF exercises, group 3 is aerobic exercises. All the participants underwent the treatment for 30 minutes. And all these group, in addition to the exercises, they underwent 10 minutes of transcutaneous electrical nerve stimulation to reduce the pain. So all the groups receive it at the frequency of 100 Hz, pulse width of 100 to 150, and the intensity is based on the patient perception. Before starting the procedure, a clear explanation was given to all the participants. Written consent, informed consent was obtained, and this study was approved by the Institution Ethical Committee. First group is motor control exercises. They underwent 30 minutes of exercises by pelvic bridging with leg raise, kneeling, pelvic tilting, cobra exercises, and plank and crunches. And the group 2 is the PNF exercises. They do alternate concentric eccentric contraction without relaxation, repeated contraction for 5 seconds in the trunk flexion, as well as repeated eccentric contraction for 5 seconds. These contractions are maintained for 5 seconds. These exercises are done for 30 minutes. And we have a third group called as aerobic exercise group. We have advised them to do walking and slow jogging for 30 minutes, which was also conducted in the department. All the exercises consist of 5 minutes of warm-up and 30 minutes of exercise program with 5 minutes of cool down, in addition to the 10 minutes of transcutaneous electrical nerve stimulation. That is 10 was applied. Frequency of exercise is 3 times per week, and total study duration is 6 weeks, that is 18 sessions. And the result was calculated using SPSS 20.0 using its analyzed data and significance level was set as alpha of 0.05. And the results, these are the result tables, and the age group is 44 approximately, it's 43 to 44. And the duration of the pain is 3 to months, and the hours of work is 8 hours, because in India there are more number of works and more labors, and they are supposed to work for more than 8 hours. And the pain score value is approximately 5.71. And the results were calculated using the SPSS system, and we have identified the functional disability of group 1, group 2, group 3. The functional disability from group 1 is 16, it reduces to 11.9. The disability was 16.7, in group 2 reduced to 12.3, and it was aerobic exercise was 16.9 to 13.9. And same as when we look at the dynamic postural balance, we have selected 3 areas only: anterior medial, anterior lateral, and posterior balance. On all these shows there was a significant differences in the balances. Whereas when we compare the balance with the other groups, and I found that there are some amount of balance was improved in the group 1, that is motor control exercises. But what happens here is that although there was a mean difference of improvement found in the motor control exercises in some groups, as well as PNF exercises in some groups, unfortunately, when we do a statistical analysis, there was no significance obtained. So when we compare the group 1 motor control exercises and comparing with the aerobic exercises, there was a significant differences. When we compare group 2, that is PNF exercises, and the aerobic exercises, it shows significant difference. But on comparing the aerobic exercises, or comparing the motor control exercises with the PNF exercises, there was no significant found. But within group analysis, that is the group in the pre-test and post-test, there was a significant differences obtained in all the 3 groups. So how the improvement occurs? Motor control exercises helps in training of the low back pain and provide lumbar stability, integration of the functional task, as well as improve functional disability. It involves in restoring the neural control, and it also helps the back pain for effective the other therapies. There are some studies shows that motor control exercise is not that much effective when compared to the other groups or other therapies, which was done even in the 2014 studies also. PNF fibers in the other area, PNF stimulates the type 2 fibers and significant role in strengthening the muscles. It also helps to synergize the muscle activity as well as increase the strength of contracting muscles. PNF therapy also helps in improving the muscular strength as well as the dynamic balances also. And when we see the aerobic, how it improves, aerobic exercises promote the central opioid system. Here the pain reduces, So because of the pain reduction, there was an increase or the improvement in the muscle function. Although there was a no obvious identification of the improvement when compared with other groups identified, but still aerobic exercises group also has improved well. Okay, so this study was concluded that the motor control exercises as well as the PNF exercises show similar improvement in the dynamic balance and functional disability. Whereas when we compared the motor control exercises with aerobic exercises, there was significant differences. Same as when we compared the PNF exercises with the aerobic exercises, there was significant differences. There was a differences noted in between the groups, that is within the groups. Aerobic exercises also improved from pre to post. Motor control exercise was also improved pre to post, as well as PNF exercise was also improved pre to post. So this study accepts null hypothesis since there was no improvement obtained. So what are these studies' limitations? Limited, the sample size is one of the main limitations what we researchers observed. And the fitness level of the individual participants was not considered in the beginning of the study. Long-term effect is not identified because it is an ongoing study. We have just completed only with the 6 months for the purpose of the research, but it's an ongoing study. We maybe the next conference we are trying to project how is the improvement occurs. The food activity, lifestyle, sleeping pattern were not controlled, as well as work activity is not controlled. Future study is focused on where we are doing it and more samples, as well as the long-term study also we are doing it. And these are my simple references. There are so many authors have done on the segmental exercises or as well as the motor control exercises, but still there was no concise evidence on that. And thank you very much, the organizers. I wish to thank everyone for selecting my paper and giving me an opportunity to present my paper on this conference. I would like to thank everyone for giving me an opportunity, as well as every researcher over here. I thank you very much. Have a good day.
Thank you very much, Dr. Arun. That was a good paper comparing the effects of motor control and PNF techniques on low back pain. Any questions from the participants? There are no questions. So thank you very much, Dr. Arun.
Thank you.
We move forward to the last abstract presentations for today's session. The last presentation is from Mr. Mahmoud Shafiq bin Mohammed Saleh from Malaysia. The title of the abstract paper is Comparison between Cold Water Immersion and Active Recovery and Perceived Pain Relief Among Male Football Players. Without further ado, I would like to ask Mr. Mohammed Shafiq to take over the session.
Assalamualaikum and very good morning, everyone. My name is Mohammed Shafiq bin Mohammed Saleh. So today I want to present my topic, comparison between cold water immersion and active recovery on perceived pain relief among men football players. So we go into introduction. Recovery is the process which allow the body to restoring to make athlete return in sport with the best performance levels. Cool water immersions, the body will immerse in the cool water, but except of the heads with temperature 10 degree to 15 degree, duration 10 minutes to 15 minutes. Active recovery is the process of the keep going in the moderate intensity, and then refer the other name, for example, cooling down or warming down. And then the process, for example, of active recovery, we perform the walking, we perform the stretching, then high intensity interval training or HIIT is categorized by the repeated intermittent bursts using vigorous exercise with the lower rest period recovery for each activity, and then delay onset muscle soreness, DOMS. A micro damage occur on the muscle tissue that result pain and soreness after perform any physical activity. So problem statements, previous studies show the different result on the muscle recovery on the different variables, for example, type of recovery use, and then effect of the different recovery use, and then duration of the recovery use. And then, however, conflicting result between the effect, cool water immersion, and active recovery after performing an exercise. So I want to clarify which method of recovery that give the most effective influence on muscle recovery after performing high intensity interval training. So my purpose of study to determine the differences between the effectiveness of two types of recovery process, which are co-author immersion and active recovery on the pain relief between 24 hours, 48 hours, 72 hours after performing high intensity interval training amongst male football players. My significance of study to gain a better understanding on the effect different recovery use after performing high intensity exercise. Okay, to get the better recommendation to the athlete, particular in football training session and competition, which method of recovery will influence their performance, and then to improve the some technique of enhanced muscle recovery for the specific competition. So based on my significance of study, will help the athlete, practitioner, and coaches, okay, to use which recovery is more benefit or give the positive effect on their performance after performing the high intensity exercise. And then my objective of study to identify the effectiveness, perceived pain relief after applying cold water immersion and active recovery at 24 hours, 48 hours, and 72 hours after performing high intensity in interval training among male football players. My hypothesis, there was significant different effects between cold water immersion and active recovery on perceived pain relief following high intensity interval training after 24 hours, 40 hours, and 72 hours among male football players. This is my methodology. The study design is quasi-experimental. My participant total is 36, age between 18 to 23 years old. The gender is the male, and then the male football players. And then, of course, there's no history of injuries. My dependent variable is muscle recovery. I use the VAF, is the visual analog scale to measure the pain relief. And then my independent variables, they have two intervention, cold water immersion and active recovery. So I take the measurement for 3 times, 24 hours, 48 hours, and 72 hours. And then lastly is statistical analysis that I use is repeated measure on OVA. This is my research procedure flow chart. Okay, total my participant 36. I distribute the PAQ information letter to them, and then I measure the anthropometric measurements. All the participants will go into the high intensity interval training before go to intervention or go to the recovery. They perform the Tabata for the 5 round, and then after perform the Tabata, they immediately go to the recovery. Okay, 18 participants go to the cold water immersion, 18 participants will go to the active recovery, and then VAS is observed on the next is 24 hours, 48 hours, and 72 hours. This is result, demography of the participant, mean and standard deviations. Okay, for the variable age, height, weight, BMI, and body fat percentage. This is my result. Okay, for the cold water immersions, 24 hours, 48 hours, and 72 hours, there show significant difference. Okay, and then also for the active recovery, there show significant difference. But in the 24 hours for the cold water immersion and active recovery, there are no significant difference. But for the 40 hours and 72 hours, they show significant difference. So means that after complete the intervention of muscle recovery, okay, they show that cold water immersion and active recovery, there is no significant on the perceived pain relief. So my discussions, based on the finding that I get, it is important for the athlete, coaches, and practitioner to know the effect on the different recovery they use on the muscle after perform high intensity exercise or high intensity interval training, and then also will help the athlete to get better performance during training and competition. It also clarify which method of recovery provide the immediate effect on the muscle recovery after performing high intensity exercise. My future recommendations, maybe some investigation, some researcher can go to the different process on the kinematic and the kinematic measurement, and then measurement muscle recovery using different type recovery process on the high profiling athlete, and then also can use the co-water emission focus to the resistance training and endurance training. So this is my references, and then that's all. Thank you for listening. Hope you enjoy it.
Thank you, Mr. Mohammed Shafiq. Is there any questions for Shafiq from the floor? Okay, we have a question for you. Which is better, active recovery or immersion? Which is better, active recovery or immersion?
Okay, so thank you for that question. Hello, can you hear me?
Yes, yes. Proceed, please proceed.
So the question about the differences between co-water immersion and active recovery, which one is more better? Okay, the preferable is co-water immersion, because we know that in the physiological co-water immersion we help our body to relieve. Okay, for example, we call it can improvise, okay, our muscles and our, we call it what the name is, our enzyme in our body. Okay, so cold water immersion is slightly better, okay, compared to the active recovery, because active recovery is only that if we perform the only the walking or stretching, okay, and then active recovery, cold water immersion also can reduce our body temperature. Okay, so this means it's good for our physiological, for internal of our body. Okay, because it's more trigger into our internal of our body for the we use the cool water immersions.
Thank you,
Okay.
thank you, Mr. Shafiq.
The question.
Yes, yes, yes. Okay. That's the reason most of the players goes for ice bath, is it?
Yes, but yes, correct. The reason that many players, okay, elite professional players, especially the high profiling athlete, now go to the ice bath, okay, to recover their body after training or after competitions, okay, because there is some evidence, okay, some give the positive effect when using the ice bath or cool water immersions for the recovery for the athletes.
Okay. That's great. That's great. Thank you very much, Mr. Mohammed Shafiq,
for
your presentation. So we have completed the abstract presentations for today's session. Thank you all. Thanks to all the participants and the presenters for today's session. We'll meet again tomorrow for our last day of our grand World Conference on Exercise Medicine.
Okay, thank you.
I used it. Nana.
Don't you lose your hopes due to hurt alone? up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so
Recording stopped.